Vanakkam. When a finger is congenitally small, it is easy to call it hypoplasia, and it is understood that all the structures in that finger are smaller than normal. But when a finger is larger than normal, it is a little more confusing because any of the components of the finger, it could be the nerve, it could be the bone, it could be the soft tissues which are increased in size. Or it could be a part of a more generalized problem where there is an increase in size of the other structures also. So only if we understand what is happening inside the tissues in macrodactyly, we will be able to understand how we can go about the management. Macrodactyly is a unique congenital difference that is seen. The word macrodactyly is derived from the Greek words macros, meaning long or large, and dactylo, meaning digit, which could be finger or toe. It is a rare, benign, non-hereditary congenital condition of overgrowth affecting the digits or toes. It affects about 0.9 to 1% of all congenital anomalies of the upper limb. It is often noted at birth or develops within the first 3 years of life. Despite being relatively rare, the impact of this congenital condition is quite powerful because it affects the appearance and function of the hand and also sometimes the psychological well-being of the child. The overgrowth can seem uncontrollable and the appearance of the digits bizarre and stigmatizing. And as we have seen, this overgrowth can affect the upper or lower extremity. It is defined as a condition in which a finger or toe is larger than normal size, secondary to excessive growth of the anatomical structures or abnormal accumulation of substances. In Swanson's classification of congenital deformities of the hand, macrodactyly is labeled as overgrowth, in contrast to undergrowth, which is also known as hypoplasia. But when we compare undergrowth or hypoplasia with overgrowth or macrodactyly, in hypoplasia there is demonstrable undergrowth of the whole hand or the component segments of the hand. But when we consider overgrowth or macrodactyly, there is bizarre involvement, and if the finger or thumb is considered one anatomical unit, macrodactyly does not involve one single unit. It can affect either half the unit, 1.5 or 2.5 units. The overgrowth components are mainly the soft tissues, especially the nerves. The etiology or the underlying cause of macrodactyly is said to be a mutation in the PIK3CA gene. This PIK3CA refers to the gene that codes for the production of a component of the phosphatidylinositol 3 kinase PI3K protein, which forms part of the cell signaling pathway. A mutation of this gene causes PIK3CA related overgrowth spectrum, otherwise known as the PROS. This PROS encompasses a variety of syndromes like macrodactyly, Clove syndrome, and dysplastic megaloencephaly. So macrodactyly forms a part of this PROS. The clinical presentation of macrodactyly is usually unilateral, and in the unilateral presentation, multiple digit enlargement is much more commoner than single enlarged digit. The index finger is the most frequently affected digit, particularly in combination either with the thumb or the middle finger. The distal portion of the digit is more commonly affected than the proximal portion, and the palmar soft tissues are more commonly affected than the dorsal soft tissues. The joints get hyperextended, particularly the distal interphalangeal joint. Macrodactyly is commonly associated with clinodactyly or lateral deviation of the finger. It can also be associated with syndactyly in 10% of the cases, as in this example. If only one digital nerve along one side of the finger is affected, in this example, the green line represents the affected nerve. Macrodactyly is confined to that side. This will push the unhypertrophied side away from the midline of the finger, causing a severe whole finger clinodactyly or lateral deviation. If hypertrophy affects the common digital nerve before it divides into the digital branches, the contiguous sides of the two fingers will be hypertrophic and consequently it will cause a divergent clinodactyly. Macrodactyly may be isolated or may be a part of a broader overgrowth anomaly affecting the proximal limb in addition to the enlarged digit. The proximal overgrowth may be segmental gigantism affecting only a part of one limb, macrodystrophica lipomatosa, which is associated with disproportionate and progressive adipose hypertrophy, hemihypertrophy affecting one side of the body associated with neurofibromatosis or Klippel-Trenaunay syndrome, or crossed gigantism affecting regions on both sides of the body. So, if a patient has macrodactyly of all digits, the remainder of the limb should be carefully examined for enlargement of any of these conditions that we have seen. Macrodactyly ultimately affects all the tissues in the digit. There is thickening of the skin with decreased sweat gland density, lipomatosis of the digital nerve, which is one of the most important features. The digital arteries are typically enlarged. Bone shows wide medullary canals, irregular trabeculae, and thickening of the periosteum, but the tendons are relatively spared. The growth of the bone and progressive deviation continue until physeal closure. Soft tissue enlargement may persist into adulthood. Almost all cases of macrodactyly are associated with lipomatosis of the nerve, LN, the massive fibroadipose enlargement of the digital nerve within the enlarged digit and sometimes extending proximally to involve the affected nerve trunk. The soft tissue swelling in the palm is mostly due to the extensive lipomatosis of either the median or the ulnar nerve branches. This clinical example shows a thickening of the median nerve causing a carpal tunnel compression. There are four main changes that occur in the nerve: adipose infiltration within the epineurial sheath, perineural fibrosis, dense endoneurial connective tissue, and decrease in the myelinated fibers. Nerve conduction studies show reduced amplitude and increased latency of the action potentials, but this could also be due to compression in the palm. Sensory impairment and weakness may also be seen. All these features are different from neurofibromatosis. The overgrowth with neurofibromatosis is different. In neurofibromatosis, the nerve trunk is replaced by a plexiform neurofibroma with increased fibrovascular stroma within the nerve fascicles rather than lipomatosis of the nerve. There are two main classification systems of macrodactyly. The first is on the basis of the rate of growth and the second is on the pathologic basis of presentation. The classification system based on the rate of growth of the finger was given by Barsky in 1967. According to this system, it could be the static type where the enlarged digit grew commensurate with the growth of the child, or the progressive type where the affected digit's growth was more than the normal digital rate of growth. A classification system based on the pathologic basis of presentation was proposed by Flatt in 1994. According to this, type 1 referred to gigantism or macrodactyly with lipofibromatosis. Type 2 referred to gigantism or macrodactyly with neurofibromatosis. Type 3 when it was associated with digital hyperostosis with involvement of the bone. Type 4 was later added on by Upton in 2005 and this represented gigantism with hemihypertrophy. In type 1, The macrodactyly is associated with enlarged fat-infiltrated nerves within the digit which can extend proximally through the carpal tunnel. It is the most common form of macrodactyly deformity. Type 2 macrodactyly usually occurs in conjunction with the plexiform type of neurofibromatosis. It is often bilateral. There may be osteochondral masses associated with the enlarged skeleton. Type 3 refers to the hyperostotic form of macrodactyly with osteochondral periarticular masses developing as early as infancy. There is no significant nerve enlargement in this type. It is very rare, it is not hereditary, but the digits are nodular and stiff. Type 4 macrodactyly is a rare anomaly without a known inheritance pattern or etiology. Here, macrodactyly is part of hemihypertrophy. All digits are involved, but usually less severe than type 1 or 2. The deformity is marked by intrinsic muscle hypertrophy or abnormal intrinsic anatomy. In this type, deformity is present with flexion contracture, ulnar deviation, and an adducted thumb deformity. But generally, the clinical usefulness of these systems is limited. The most important thing is to distinguish the cases of overgrowth associated with specific syndromes. Let us see some of the syndromes associated with macrodactyly and their distinguishing features. In neurofibromatosis, we'll find cafe au lait spots, skin pigmentation, multiple neurofibromas, sometimes pedunculated skin lesions and ocular lesions. In Olier's disease, we will find multiple enchondromas. In Maffucci syndrome, multiple enchondromas will be seen along with hemangiomas. In Parkes-Weber syndrome, limb hypertrophy, length discrepancies, capillary malformations and arteriovenous malformations will be the features. In Cloves syndrome, which stands for congenital lipomatous overgrowth, vascular malformations, epidermal nevi and scoliosis or spinal deformity. In Klippel-Trenaunay-Weber syndrome, cutaneous hemangioma, atypical varicose veins and hemihypertrophy will be the feature. In Proteus syndrome, hamartomatous dysplasia, macrodactyly, pigmented linear epidermal nevi and subcutaneous hamartomas will be the features. X-rays of the macrodactylus digits will show enlarged skeleton with advanced bone age compared to the normal digits. In this example, you will note that the epiphysis has not yet fused on the middle phalanx in the ring finger, whereas on the middle finger, which is affected by the macrodactyly, the epiphysis has almost completely fused. Another feature is that skeletal enlargement is more marked in the antero-posterior and transverse dimensions of the phalanges rather than the length. Phalanges may be trapezoidal with deviation of the digit. Osteoarthritic changes may be noted early with osteophyte development. Osteophytes are the dominant feature of the hyperostotic variant, that is flat type 3. Periarticular exophytic osteocartilaginous masses are typically seen, and when these occur, they are typically not associated with enlargement of the peripheral nerves. The management of macrodactyly is mainly surgical due to functional and aesthetic causes. But even surgically, macrodactyly is difficult to treat, and that is because of the progressive and diffuse nature of the condition. So counseling is a very important part of the management. We need to discuss the expectations of the parents and the child. We need to emphasize the inability of surgery to establish a normal looking digit and also the requirement of multiple surgeries. As far as the surgical management of macrodactyly is concerned, there are 5 main options or protocols for surgery. Procedures for limiting the growth, procedures for reduction in size and realignment of digit, procedures for correction of deviation, procedures for management of thumb macrodactyly, and finally amputation. When we talk about procedures for limiting the digital growth, we need to talk about procedures that limit the transverse growth and the longitudinal growth. The main described procedure for limiting the transverse digital growth is stripping the branches of the digital nerves, sometimes even resecting the entire digital nerve. We are always worried about a sensory deficit following the ablation, but it has been proved that it is less than expected because the remaining nerve is adequate to supply the entire skin envelope. Next, we come to procedures to limit the longitudinal growth of the finger. This means that we will have to deal with the epiphysis. We can do an epiphysiodesis of the phalanges using a burr or drill to ablate the physis, or sometimes even direct resection of the epiphyseal plate. It can be combined with a closing wedge osteotomy to not only limit the longitudinal growth but also correct the deviation deformity. Epiphysiodesis is performed when the digit reaches the length of the corresponding digit in the same sex parent. Percutaneous K-wires are often required to stabilize the phalanx after physeal resection, particularly if combined with a wedge osteotomy. The physeal arrest will not reduce the soft tissue growth or the transverse growth of the skeleton. Epiphysiodesis is not without complications. We can have joint stiffness, excessive bone formation at the site of the physis, or secondary angulation after incomplete physeal destruction. Procedures to limit the growth of the digit are important, but we also need to do procedures to reduce and realign the digit. This will mean that we need procedures for debulking soft tissues, for debulking the nail complex, and for skeletal reduction. For debulking of the soft tissues on the finger, one side of the digit is usually debulked at a time, and a mid-lateral approach is advised. Through this incision, a wedge of skin, fat, and digital nerve is resected. The digital artery should be carefully preserved. For debulking the nail complex, the lateral nail fold is raised as a dorsally based flap. Resection of a lateral wedge of the sterile and germinal matrix and underlying lateral margin of the distal phalanx is done. Resection of the volar tuft and distal tip of the distal phalanx can also be done to reduce the dimension of the fingertip. After debulking the soft tissues and the nail complex, it is also important to do a skeletal reduction. This skeletal reduction must be to get narrowing and shortening of the bone. To get narrowing of the skeleton, we can do resection of the sides of the phalanges, and this is typically done for the terminal phalanx. We can also do a central longitudinal osteectomy in sagittal and coronal planes. But obviously these longitudinal osteectomies are less commonly performed. And that is the reason why the excess girth of the skeleton remains. When we talk about procedures for shortening the bone, if the digit is angulated, it can be shortened by doing a closing wedge osteotomy or a corrective osteotomy. If it is at the level of the distal interphalangeal joint, arthrodesis will also help in shortening the bone. There are also a few standard procedures for shortening the bone: the Barsky technique, the flat technique, the Suge technique, and the Rosenberg techniques. Barsky's technique involves shortening the digit by filleting the distal phalanx, excising the skin over the dorsum of the middle phalanx, and placing the nail as a free graft on the end of the middle phalanx. The Adrian flat technique is by preserving the distal part of the distal phalanx and fusing this to a shortened middle phalanx to reduce the length of the skeleton. The excess palmar skin produced by the shortening can be excised at a second stage. The use of the palmar pedicle maintains a reliable blood supply and good sensation in the distal finger. In the Kenya Suge procedure, the nail is preserved on a dorsal skin pedicle, including the dorsal cortex of the distal phalanx. The digit is shortened with excision of the pulp and the palmar aspect of the distal phalanx. The nail is then fitted into a recess on the dorsum of the middle phalanx. A fold of skin is thus produced on the dorsum of the digit, which can be revised at a later stage. The dorsal pedicle, however, has proven to be unreliable in the fingers but has been used in the toes with success. By the Rosenberg technique, the nail is transposed further by raising the nail unit as an island flap on the digital neurovascular bundle. After excision of the distal phalanx and the pulp, the nail unit is repositioned on the dorsum of the middle phalanx as a pedicled flap. Another procedure for reducing the length of the skeleton is by excising the middle phalanx completely, but this will result in both a dorsal hump and a palmar hump, which will have to be excised later. After procedures to limit the growth of the finger and also to reduce the bulk of the finger, we also need to correct the deviation in some cases. Closing wedge osteotomies can be done where a wedge of bone is excised with the apex pointing towards the concave side, the remaining skeleton fixed with the percutaneous K-wire. These osteotomies can be combined with other debulking procedures or growth limiting procedures. Reduction of the thumb can also be done using similar techniques. Here the shortening can be performed via metacarpophalangeal arthrodesis or oblique osteectomy of the proximal phalanx. The Millesi technique is commonly used for reduction of the thumb. This is a more complicated pattern of reduction osteotomies that preserves joint motion. The nail width and length are reduced, but the central nail is excised. This technique results in ridging of the nail. The central portion of the terminal phalanx is also excised and the two lateral edges brought together. Finally, we shall see the role of amputation in the treatment of macrodactyly. After all, the ultimate reduction procedure is amputation. It is ideally indicated for macrodactyly isolated to a single digit that is progressively growing at an uncontrollable rate. Doing the amputation may be a good option, but it is important that amputation be considered early in these cases to limit the trauma and avoid multiple procedures. The level of amputation done in different conditions should also be considered. Disarticulation through the distal interphalangeal joint can be considered for distal macrodactyly, but the absence of a nail can make the digit conspicuous. For a border finger, ray amputation is effective and creates an adequate first web space in the case of index finger. For a central digit, however, a ray amputation will cause a gap between fingers and considerable loss of function may result. Hence, for a central digit like the middle finger or the ring finger, transmetacarpal amputation needs to be done and transposition of the adjacent digit, either the index finger for the middle finger or the little finger for the ring finger, needs to be done. In this example, the macrodactyly of the middle finger is treated with amputation at the level of the middle of the third metacarpal bone. A plate is fixed here and the index finger is osteotomized at the middle of the metacarpal and transposed to this middle finger metacarpal. Alignment of the fingers and the rotation is considered and then the wounds are closed. There are situations where both the index and middle fingers are involved. They can be amputated, but a second toe transfer for digit reconstruction can be done to create a 4-digit hand. This has been reported and it was also seen that there was no overgrowth phenomenon within the transferred digit. Similarly, when the thumb is involved, amputation of the thumb should be avoided unless the overgrowth is unyielding to preclude any function. But reconstruction must be done either with a toe transfer or a polycization as shown in this example, where the macrodactylus thumb and the index finger have been amputated and reconstruction of the thumb done using polycization of the intact middle finger. Management of the special cases like hyperostosis associated with macrodactyly is different. The main problem in these patients is the loss of motion. It can be managed with osteectomy of the osteochondral masses, including part of the volar plate. Arthrodesis is often required after the digit attains adult length. Implant arthroplasty can be done for replacement of the metacarpophalangeal joints. In conditions of hemihypertrophy with macrodactyly, contracture of the digits is commonly present due to abnormal extrinsic and intrinsic musculature. Contracture release, debulking of the hypertrophic intrinsic musculature, soft tissue rebalancing, and skeletal correction would have to be done in these patients. The expected outcomes after surgery for macrodactyly reduction depend on the initial condition of the hand. No surgical procedure results in what is expected to be a normal appearance. The final appearance and function are variable, and surgery also has its inherent risks: hypertrophic scarring and neuroma formation. Research has shown that it is possible to do a non-operative treatment for macrodactyly. Advances have shown that in understanding the mechanism of overgrowth in macrodactyly, the PIK3K AKT mTOR pathway of intracellular signaling is implicated. Inhibitors of upregulation of this pathway have been used in oncology. Can they be used here in the treatment of macrodactyly? Clinical studies have been done in a group of patients. The results are encouraging but still not definite. I hope you liked the video. I enjoyed making it. Please do click on the shown links to see more about radial club hand and its management. And do not forget to subscribe to stay connected with the latest in learning, hand surgery, trauma surgery, plastic surgery and ethics. Vanakkam.